Welcome from the endoscopy unit of San Raffaele Hospital. We are ready with the cases, and so we can start presenting the first case of the day. Thank you for coming.
Our first patient is a 37-year-old Hispanic female with a medical history of ovarian cyst rupture and hemoperitoneum. In December 2017, for postprandial abdominal pain and mild pancreatic insufficiency, the patient underwent an Euro-Eus showing an atrophic parenchyma at the pancreatic body and tail, and a dilation of the pancreatic duct, 7 millimeter in the head, with echogenic material inside, not announced after sonoview injection, maybe mucus or plaques. This is the images from the Euro-Eus before and after sonoview. Today's scheduled procedure is Euro-Eus with or without ERCP, with operators Drs. Saftoiu, Mariani, and Tyberg.
Good morning. Can you hear us?
Yes, Adrian, we can.
Okay.
We see you and we hear you.
Okay. Good morning. One more time, we have quite a large team here, so everybody is in the room. So we hope we will solve the case. It's quite interesting because we are facing a young lady without any familial history, only with some postprandial pain, and we decided to use the usual scope. So we have the Pentax EG3870 UTK, so it's an usual US scope with large channel. It's not the slim scope, so it's the usual scope. Together with the Euro-Eus system, and we are already in the duodenum, and you see that already the vascular, let's say, landmarks. So you see the SMA and SMV, and then you see the pancreas, and you already see we've tried a bit to play with the image. And first, you need to increase or decrease your image to see things in a proper way.
Can we have the US image, please?
Do you see the US image, or Julio?
Just is it very small? If we can see it large. Okay, great.
Okay.
Thank you.
So you can play a bit with the settings in the ultrasound system, so you can enlarge, increase or decrease the image size just to see, and you already. You can see that the whole pancreas is inhomogeneous. There are some focal bands, focal strands, and hyperechoic bands. So there are a lot of criteria which might lead you towards the conclusion that the patient might have chronic pancreatitis. So then you look at the parenchyma, and then we are trying to see the ducts. And you see that there is one duct. I'll try to show it here. So there's one duct here, which looks normal, but at one point it becomes a bit more dilated. And what's suspicious is this lesion here. So it looks like a focal lesion. So everything is, let's say, she has diffuse changes in the pancreas, but maybe with a small focal lesion here. So we've concentrated a bit on this lesion because this is a bit more suspicious than the rest of the parenchyma. And if you look at it, we can, of course, measure it. It's about 8 millimeters, so it's not big. So you can appreciate the resolution of the system. So it's 7-8 millimeters. It's not big, but it's hypoechoic, so it looks a bit more suspicious.
You place this lesion, Adrian, inside of the PD, or?
Yeah, we've discussed a bit. We are not sure. So if we start from here, you can see the pancreatic duct branches. And if you look here, it looks like it's inside. So it might be a mucin plug we've discussed. It might be a mucin plug. It might be a focal lesion. We don't know. So we need to characterize this one a bit. So you see there's no Doppler enhancement, but of course we can do contrast. Doppler is not sensitive enough for really tiny vessels, for small vessels. So what we decided to do further is to do a contrast examination and see how it looks. As far as I understood, she already had a contrast examination which was negative, but we want to see it one more time. We have the settings already in the system, so we can do one more contrast examination. Until we prepare the contrast, I will briefly show you the elastography, because we've tried elastography on the lesion, and you see that there's a mixed pattern inside the pancreatic parenchyma. So elastography is here, it's more or less helpful, but you see that inside a focal lesion, things tend to be hard. So it looks a bit suspicious, so we will try to do a contrast further on. And I'll come back on the elastography. So let's try and change the settings for the system. And we have already a vial of Sonoview. I'll increase a bit the image. Then we'll try like this. Just a moment until I increase a bit the mechanical index. So we usually work with the mechanical index of 0.2. So let's try now and locate again. The lesion is probably here. So the most critical part for the contrast examination is to have the lesion inside the in the image field of view. So we can try right now. So
how much are you going to inject, Adrian?
it's one vial. It's 4.8 usually. So we prefer one vial, and you already see the contrast in the SMA. So you can see it here. It's not enhancing here. So you see the contrast coming now in the pancreatic parenchyma, but inside the lesion, it's not much.
So what would be your impression with this Sonoview information?
Sorry, Julio, I didn't hear very well.
What's your impression now that you've seen a little bit of elasto, you see the V-mode imaging, optimized imaging, and now with this Sonoview aspect of this lesion?
It's not enhancing. I think it's not enhancing. That's one point. And if you look at the Sonoview aspect, now you see the contrast already in the venous system. So you have the artery here, the vein here. But if you look in the pancreatic parenchyma, there's not much contrast. So I'm not sure. What would you say? Is it chronic pancreatitis or is it a mucin plug? Because the contrast, there's not much inside the pancreatic parenchyma. There are, of course, some tiny vessels here, but I think the lesion here is not enhancing. So I would say it looks suspicious. So what I would do further in this case, I would do an FNA. Because elastography and contrast are not really conclusive. So what do you think? Do you have any other suggestions or questions?
I think in this case with the clinical picture, it looks like chronic pancreatitis, but of course there is that suspicious lesions inside of the PD. But if it's a young patient, the decision is very important because it seems to be a nodule inside, and the only way to really differentiate that nodule, whether it's benign or malignant, or whether it's just a mucin plug or not, probably is just to use to make an FNA. What's any question in the audience about the case? Any doubt? Any comment to Adrian?
Yeah, it's okay. 25, it's okay. She's
advanced
young.
imaging guy, so please.
Let's switch it back to this one. I'll switch the system back to the grayscale image. Let's increase a bit the size. And you can see again the lesion, and you can nicely see the contrast. That there's still contrast here in both the artery and the vein. So, and you see the lesion. The lesion is here, but it looks suspicious. So it's hypoechoic. Might be in the pancreatic duct. So let's see the final aspiration, and if we can get some material. So because it's a young patient, we decided we will use a 25 gauge needle. Okay. We can
In
do
these
it.
cases,
We
would
still
you
have
prefer
5 minutes.
And Adrian, will you go better for an FNA needle or will you go for an FNB needle?
I think we will start with an FNA needle. She's young. She's 37 years old. She doesn't have too many symptoms, only some postprandial pain, but she has pancreatic insufficiency. So I think we will start with the 25 gauge needle and see what it comes up.
Would you use a FNB needle in this case, or?
Yeah, that was what Julio asked, but I would start with a 25 gauge needle just to rule out malignancy. And then, of course, if you want microhistology, then you can use an FNB. But I think we can get coarse with a 25 gauge needle as well. So we'll try to use.
Complication-wise, it has been shown that it doesn't matter. The size, in this particular case, it doesn't matter.
Okay.
No, and you also have Professor Doglioni in the room, so it's very easy with Professor Doglioni to use a 25 gauge needle. So in the audience, I would like to raise your hands.
Thank
Which
you
of
very
you
much.
would use a 25? How many of you will go for a 22 standard? And how many will just try to use an FNB needle?
Can I please
So we
ask
have
you
a
to
variety
just
of
hold it
answers
here?
here in the audience. There's a lot of people who would love to use a 22, and some others will go for an FNB needle. I think, in my opinion, it has a lot to do with your pathologist. I mean, probably if I will be working in Milano with Professor Doglioni, I will probably go for the 25 gauge because he has a huge experience and a huge ability to
We're
obtain very good
close,
diagnosis.
I'm not sure.
Yes?
We can try here. It's okay. I think we are inside. Yeah. Okay. You can
where
leave this
would
one and
you,
take the stylet and
Go to if
I
the
can
sort
keep
of
it here.
FNA
Thank you.
comes back inconclusive. Because you've done elastography, you've done sonoview, now on the basis of that and your FNA is iffy, where do you go from there?
Adrian, there is a question in the audience, and,
Okay.
and what happens if it's unconclusive in the FNA?
We have
What would you
discussed
do?
that, and the further you can take it out, and we were planning a further ERCP in this patient, maybe with confocal. So that would be the next procedure that we are considering here, because she has pain. So and the pancreatic duct is dilated, so we can at least she can have a pancreatic duct stent placed in there. So that's what we are considering next, an ERCP.
This is the problem, because we want to see you. Pardon? No, I have the monitor.
Okay.
Is
I
any
think
other
you
question
can
in the
take
audience
it out.
for the case? Do you feel hard the lesion, Adrian, or
No,
soft
it's quite soft.
while doing the punch?
Yeah, it's quite soft, but you see that the whole pancreatic parenchyma is moving, so it's quite soft.
Adesso presentiamo il caso della sala 5, ok?
Okay, we can take it out and maybe place should we place a vacuum and do some slides? Yeah, or should we place a vacuum? You can take it out, or you prefer it like this? Okay, it's okay. It's okay.
Diamo sempre l'immagine anche
It depends
dell'ecografia.
from place to place. That's why. Okay.
Passo, ripetiamo la presentazione. Adrian,
Yes.
while we are waiting for the results of the first biopsy, we are going to present the next case, and then maybe we'll be back to you for the final decision.
Okay.
So we go to present the case in room number 5.
Next patient is a 62-year-old male with medical history from 2012 and 2014 of episodes of recurrent acute pancreatitis. In 2013, the patient underwent EUS and FNA with evidence of multifocal branch duct IPMN of the head, thick walls, 20 millimeters. FNA showed mild dysplasia. And of the body and tail of the pancreas, 15 millimeters with a solid component, FNA showing moderate dysplasia. In 2014, the patient underwent distal pancreatectomy. From 2014 and 2017, the patient underwent a regular follow-up of the cephalic branch duct IPMN. In October 2017, the US showed a 25 millimeter cystic lesion with thickened walls, not enhanced after Sonoview injection. A follow-up CT scan in February 2018 showed a micronodular areas inside the cyst. Today's scheduled procedure is EUS and FNA with operator Dr. Farrell.
Hello, James.
Good morning, buongiorno. I'm James Farrell. I'm here with Luca and Gemma. And so you heard the case history there. If you can put up the EUS image, we'll show you what's going on. We're down in the second portion of the duodenum with a linear echo endoscope. And it gives us a much better view, being a little bit further down here. And you can see this lesion. So it measures just under 2 centimeters and cystic for sure. But I think there's a couple of things to point out to you if we just freeze this very briefly. If I can do this here, and we have our cursor. Where's our cursor? Here we go. So if I can just show you the cursor. So here on one of the walls is really what looks like a thickening, more of a nodule in appearance. And the wall itself is quite thick, even considering what most cysts look like. And the other third thing just to bring into view is a little bit concerned about some calcification in the wall. And if I get this going again, there's some calcification kind of off screen to the right. And it probably goes in keeping with the patient's recurrent attacks of acute pancreatitis. It raises the issue of whether or not this patient has some underlying chronic pancreatitis. And frankly, I think it also just raises the possibility, although we think this is an IPMN, and some of the biopsies from the past suggest it's an IPMN, the patient had a previous IPMN, but actually could this be a pseudocyst? And is there any way of sorting this out? So I don't know if anybody has any questions to start with. We've been kind of trying to formulate a plan here for how to approach this.
Is any question in the audience about the case to James?
So any ideas about... Yeah?
I mean, this is just the isolated, this is the only cystic remaining lesion in
this is the only
case.
cystic in the lesion. We had a good look at the head from the duodenum and duodenal bulb, and there's nothing else going on there. And this is far down. This is almost, probably just hanging off the uncinate, a little deeper down, but in the pancreas head region.
And do we have changes in the pancreatic parenchyma for chronic pancreatitis in this case? Is there any, yeah?
There is a little bit. You can see some stranding there, some hyperechoic strands and foci. I'm just kind of getting used to the imaging pattern using this echo endoscope. But there does appear to be some stranding there. And as you know, the patient did have recurrent attacks of acute pancreatitis during their initial presentation. So it just does raise the possibility of either this being concomitant chronic pancreatitis on top of the presence of an IPMN, or whether it's just all IPMN in of itself. So we're interested in trying to further characterize the wall and the nodularity. So we thought that we would start and do some contrast EUS to begin with. So we're going to go get that set up first, and then we can make some decisions about biopsies. So we're going to kind of look at this with the view in, and then we're going to give an injection of Sonoview and wait and see if we see any enhancing. So we can go ahead and do that. So we're primarily interested, on the left you have the regular mode image of the endoscopic ultrasound. On our right, at least here, we have the contrast enhanced imaging. And we're waiting to see now if we can see anything light up on the wall. So the injection has gone in. And just for those folks in the audience who, I'm imaging from left to right. So typically my portal vein would be on the left side in the duodenal bulb. So I've just oriented it here because that's what I'm used to doing, just to make my life a little bit easier. But just if anybody's a little bit confused by the orientation. So this is the contrast is in. I can't really tell you that we're seeing anything light up. So that raises a couple of questions if it doesn't light up. So one of the questions is there any epithelial nodularity in there that we can I'll get a better picture here for you. Or is this all inflammatory, or if it was an IPMN, if there's some concern that it might all be mucin? So we've been looking
at...
Yes?
With that SonoView image, James, would you just rely on SonoView, go more for a retention cyst, for instance, or would you still, with that very tiny spot uptake in that wall, would you think on doing an FNA in this case, just to confirm? Because the patient has already been operated upon because of an IPMN. What's your real impression after this advanced imaging regarding this cystic lesion?
I think we just don't know. We still don't know. I think if we were going down the path of thinking this was an IPMN and this is an epithelial nodule, I would have liked to have seen some enhancement of that nodule, and at least of the wall. And so now it raises issues of, could that be mucin? Could it be debris? Or, as opposed to it being epithelium. And so the ability maybe to get some tissue and to biopsy it, I think is reasonable. And I think that's kind of our next approach here, is really to try and push this diagnosis. From what I remember of this particular patient, all the previous biopsies, and we can go ahead and get a 19-gauge FNA needle ready, all the previous biopsies that were taken, atypical cells, mild dysplasia, very, very non-specific. And the question is, how much proof do we need one way or the other to talk about sending this patient to surgery? And surgery for this patient would be likely a completion pancreatectomy to remove the head of the pancreas. So it's a big deal. And the question is, what sort of proof will we need? So if we get positive tissue diagnosis with more biopsies, will that sway us towards recommending surgery? If we get a negative biopsy, will that tell us that, we can continue to survey? I think we all get a little bit anxious when we survey patients who've got nodules or epithelial thickening. So I think this is a great example of where I think we need to throw everything, including the kitchen sink, to try and improve our diagnosis of what this cyst actually is. So let's go back to normal imaging, and I'll take the 19 gauge. Where are we? I'll take it here. Yep, we'll do it here.
Why did you choose a 19 gauge needle? I mean, we realize that you're in deep in the duodenum. Would you prefer to use a 25 or 22 instead of a 19?
I would. We're hoping to do a Moray biopsy forceps. And so in order to do that, it's better to start with a large gauge needle, such as a 19 gauge needle. So we'll see if we can manipulate the scope. We'll undo the locks, see if we can get down here and just... yeah, it's in. So if you want to hit the end of view for me, I'll just come back to the bulb. So it is. So it's an issue with the 19 gauge needle. I'm going to come back slowly, and we're going to try and just get the needle down. We're going to straighten the scope. I think we've come back into this. Actually, we're still in the duodenum. I'm going to come back a little bit. Maybe we'll just come out into the stomach. So now, by straightening out the scope, and this certainly is an issue with most 19 gauge needles, but we're going to prime ourselves and try and get down there and see if we can get back into that area. Here we go. Yeah, sometimes it's not easy to deploy these needles. That's not good.
How many in the audience went for a 19 gauge needle like James? Raise your hand.
That fell off. Oh, that's loose. Yeah, that's loose. If you can try and tighten that.
I think James will, as I understand, will try to do a moray. I think the moray, in this case, is a very... Have you any experience in the audience with the moray forceps? And what's your impression? I think there's only one concern with the moray. I do not know if the company is here, is the price of the forceps, which is, I do not know in Italy, but in Spain it's a little bit expensive. But it's true that in selected cases, the moray gives you a lot of very, very nice information regarding the type of lesion. And in fact, we've made a couple of big changes in the management thanks to the moray that really changed absolutely with the histology of the wall, the final diagnosis of the lesion. So I think I agree with Elizabeth that and if you attempt to use the Morey, which I prefer than using the Selviccio,
We popped it out, right?
you need to go for an ending course is the only way to use it.
We'll try again. Just going to bring this back just a little bit. Yeah, so we're just trying to manipulate the scope back down with this 19 gauge needle. We were down there. Let's see. Just give me a little bit of air for the. We'll clear out the stomach. Here we go.
Is any other comment about the case?
James?
We have Paolo again.
Yes.
James, while you are trying to find the right position, we go back to room number 7 where Adrian has performed already another biopsy. So we ask what is his final conclusion.
Take this out
So,
for 1 second.
Adrian?
We did 2 passes, but I will leave the microphone to the pathologist to give you some information.
We cannot hear you, Professor Doglioni.
Unfortunately, we do not have material for a diagnosis. We have only bloody material, and so I'm asking to repeat, if possible, the pass.
So what would you do? Because we discussed also repeat FNA with a core needle. Then the other option is to move to ERCP and maybe do some confocal before pancreatic duct stenting. So I don't know. We can do another pass with a 22 gauge needle, a Procore if you have. We'll try one more time.
Aspetta che lui...
If you have a 22 Procore or a Procore, yeah, acquire is okay.
Adrian?
We're going to change the.
Adrian, Julio,
Yes.
while we are waiting for the 19 gauge needle in Adrian, we go and present the next case in room number 4.
Next patient is an 81-year-old female with a medical history of arterial hypertension, hysterectomy for fibromatosis, and appendectomy. In December 2017, the patient had an incidental US finding of a main pancreatic duct dilation during investigation for MGUS. CT scans showed a 2.5 centimeter solid lesion of the head of the pancreas, suggestive for malignant lesion. EUS performed elsewhere confirms the lesion of the head, but the FNA was inconclusive. The patient is currently asymptomatic, has no diabetes, and CA 19.9 is not available yet. Today's scheduled procedure is EUS plus FNA with operator Professor Dietrich.
We on screen? Good morning, ladies and gentlemen. First of all, thank you so much for the invitation to beautiful Milano. Today there is sun outside, but please stay in the room. First of all, I'd like to introduce my family and my baby. My family is Roberto at the camera. It's Veronica, she is the anesthesiologist. It's Maria Emilia, and it's Karsten and Elfina behind me. And my baby is a Pentax EG3870UTK. And I'm in front of the pylorus, and now I'm penetrating the pylorus, going down deep into the duodenum. And first of all, there seems to be a lesion which looks like a pancreatic abscess. Can you see that lesion right on here?
Can we get the EUS image, please?
Can you switch to the EUS image? Is it available? Please give and please confirm. Can you see it?
Okay. Yes, Christoph.
Okay.
Now we have it clear.
It looks almost like a pancreatic abscess with that fine echoes inside, but it's a kidney cyst, so we shouldn't be confused. Like in all maneuvers right now, deep in the duodenum, it's the right kidney, I do the ERCP maneuver. That means the dancing, the small wheel to the right, the large wheel in front of me, and I try to come to the uncinate process of the pancreas, which we can see somewhat here. From this position, I try to be as relaxed as possible, and then coming closer to the papillary region. And slowly, you can see the pancreatic head is larger than assumed. It's up to 8, sometimes 10 centimeters, and in average, it's 5.5 centimeters. So I'm coming closer and closer to the papilla, or no, in this procedure, I even went out of the position, so I have to readjust my position, and I try to identify from caudally the region of the papilla. Slowly, here we are. Okay, so the image is coarse, white and black, and often I come to a position like that, and now we try to improve what happened here. So we try to improve the image. First of all, from a low frequency, we go to a high frequency because we are in the near field. Second, if we send out an echo, we get back an echo. But if we sing together the A, let's sing the A. A. Our tone is pretty much the same, but we sound different. And therefore, we use tissue harmonic imaging as a second way to improve our image. Third, let's go into the near field. That means we are interested in the papilla, and therefore, why not showing the papilla of the common bile duct?
Christoph?
Then,
Christoph?
yep.
Can you hear me? We will be back in 1 minute. We go in the room number 5 because James has been able to penetrate the cystic lesion. Okay. 1 minute. James? James? Sala 5, così com'è. James?
Yes, we're here.
Okay.
We're here. So, yeah, with the 19 gauge, a little bit more difficult to get down. We repositioned it. We got down. We've managed to get this 19 gauge needle in this position into the cyst. The wall actually is quite thick and quite difficult to traverse, but we've managed to get it into the lumen. We're in a slightly different position than we were before, but we're in the cyst. The tip of the needle is there, and we're advancing a moray biopsy forceps through the needle. So you see the 19 gauge needle coming from right to left into the cyst. As we're advancing it, we don't see the forceps just yet, but we're hoping to see it any moment. Yeah. So for those who haven't seen, these are very small biopsy forceps that can fit down a 19 gauge needle. Essentially, there we go. So there it's coming out. You can just move it back and forward very slowly. So we're there. So it's a standard biopsy forceps. We're trying to target the far wall. So I think we can, let's see if we can demonstrate the biopsy forceps opening. By opening, we might have to put a little bit more out. Let's see if that'll open. Yeah, put a little bit more out. Yeah, push it out a little bit more. Just close, yeah, there you go. Now open it, see if we can open it here. Okay, yeah. I think we see it open, okay. So there's different techniques. I mean, this is a relatively new technique for getting tissue from the wall. And what we've found is you really need the force of the needle to try and push into the opposite wall. So again, a 19-gauge needle. So what I'm going to do with the biopsy needle, with the biopsy forceps actually open, I'm going to take the FNA needle and try and push it forward into the opposite wall. And then when I meet resistance, and we think we're on the opposite wall, we're going to ask that the biopsy forceps be closed. So we'll close. And then I'm going to use, if we can show this, I'm pulling back, and we expect to see a little bit of tenting. There. And now we're going to take the biopsy forceps out. Typically, I just do one at a time. They're such valuable pieces. And we're going to take that out. Yep. If anybody has any questions. So what we've decided to do here is I'm going to try and hold my position, unfortunately, just because it's a little precarious. I don't know if we can get over to what's going on the table behind us. There's different ways of dealing with this, but we've decided that we're going to try and elute it onto a slide and just pick it off. And then we'll go ahead and put that in formalin. But it's really to see if we get a piece of tissue and to see what we get.
James?
Yeah.
So,
James?
Yes.
Nice demonstration of the forceps. We go back to room number 4 to Christoph, and then back to you just to discuss the results of the biopsy. Okay?
Okay.
Christoph, thank you for waiting for us.
Yeah, I love to wait. It's my whole life. So I started to improve the image, and I started, first of all, the depth penetration to focus to what we are interested, and we are interested here to the papilla of the common bile duct. Second, we improved the frequency. We went from a low frequency. We had a very bad image. We went from a low frequency to a high frequency. Then we took tissue harmonic imaging to get not only one echo, but also the harmonic echoes as well, to have a better delineation. Then we increased the dynamic range from low to as high as possible. So this is a low dynamic range, white and black. And right now we put it up to 88 or something like this. It's relative. We get much more grayscale. And then we took persistence from low to high. That means we took many information from the previous image into the next image. And then we took the compound level. That means not only one level, but the transducer gives information from the whole volume. So we did about 10 different modalities to improve our image. What for? Right now we have the papilla, and in the papilla we might have a few like that, and we can see quite nicely that the region of the papilla, on the left side you can see the image, on the right side is not infiltrated by anything. It is softer. It is not soft because we always compare in an image the surrounding with our, target. And the target in this region is softer, so no malignant infiltration. Then I'm focusing and playing a little bit with the distal common bile duct. You can see in a pretty relaxed position, and it's compressible. So I use elastography by my scope as well. Then I'm try to get a little bit the upper part of the common bile duct, and we can see quite nicely that there is an infiltration of the bile duct, as you can see next to the arrow. So let's go and see that there is a tumor infiltration of the common bile duct. Can you see it in the audience? Is it?
yes, Christoph.
Yeah.
Yes, we can.
So we can see that the distal 2 centimeters of the papilla of the common bile duct is not infiltrated, but let's say 2 or 3 centimeters above. And as you can see here, the distal part of the pancreatic duct joining to the papilla quite nicely. Can you see the course of both ducts next to the papilla in a pretty relaxed position? So from this point of view, we have a certain sign of malignancy, which is that the bile duct is infiltrated. And we can see nicely the location where this bile duct is infiltrated. At this occasion, only from a didactic point of view, we might consider to use sonoview and elastography to better characterize that lesion. But you can see also that I totally understand that the previous people have not been successful by puncturing the lesion, because it's not a very stable position. It's a pretty difficult position for a puncture. Right now, what we are doing is to get good relative image of elastography. And I would need as you can see, this tissue is reproducible, stiffer in that region of the tumor, stiffer, comparative. When to measure, elastography shows red and blue screen. We should have the lesion, if possible, in the center, and we use to analyze during decompression. And the pre-compression of the instrument also plays a role. I have a pretty pre-compression in this situation, so we have to take care of that we analyze during decompression because it's most reproducible. So why not trying the contrast-enhanced ultrasound? So we will change to the multi-harmonic imaging, try to get the lesion in to the center. Proximal of the lesion, we see the common bile duct infiltrated, as you can see with the arrow. And right now, we could start the counter. You would be ready? Yeah, please. Okay, and then we will wait. We inject it. The focus should be downward. We see quite nicely the enhancement. Is it nicely to be seen? And then we will do a short period of accumulation. Wow. We nicely depict that this lesion is much more less enhancing than the surrounding tissue. So it's a hypovascular lesion, and ductal adenocarcinoma are hypovascular if you do it right in almost all cases. So we have proven that there are arterial vessels. You can see them. Can you see them also in the audience? Like that, a little bit better? We can see the duct.
It's a very, very, very nice image.
You can see the distal part of the bile duct, which is echo-free. So we have an excellent, how to say, contrast spatial resolution. And the question was, elastography, stiffer than the surrounding tissue, contrast, hypovascular, and using contrast-enhanced ultrasound, therefore hypo-enhancing. So that was our first job. And right now, it's getting a little bit more complicated because this position, as you can see, the distal part of the bile duct and the proximal part of the bile duct, and you can see the infiltration of the pancreatic tumor in between. It looks easy to puncture, but I have the large wheel really in a somewhat extreme position. So I'm not quite sure if I can handle that, but I will use, because I need flexibility, not 19, not 22. I will use the 25 needle due to flexibility to come back into this position as good as possible. So I would need a little time to arrange the needle and to
Christopher?
fit. Yeah.
While you are putting the needle, we present the next case. We'll be back to you in 2 minutes.
Yeah, so I will take my time and I will try to get it in a good position. Thank you so far. Okay.
Next patient is a 79-year-old male with medical history of stroke, arterial hypertension, prostatectomy, hernioplasty. In March 2018, for loss of consciousness and jaundice, the patient went to the emergency room. Blood tests showed an increase of the white blood cells and C-reactive protein. Total and direct bilirubin were increased, 5.5, then raised to 10 later. And there was also an increase of gamma-GT and alkaline phosphatase and transaminase. Abdominal ultrasonography showed a dilation of the common bile duct, 18 millimeters, gallbladder filled with stones, and material in the common bile duct suspicious for a stone. Today's scheduled procedure is EUS, with or without ERCP, with common bile duct stone extraction, with operators Sowade and Santo.
Assad?
Good morning.
Good morning.
Can you hear me? Can you see me?
Yes, we hear you and we see you very nice.
Okay. First of all, this is I'm Dr. Assad Sweet from the American University of Beirut, Lebanon. I'm going to be doing this demonstration today. You heard the history on this gentleman. So there is a suspicion of common bile duct stones. And before I show you the endoscopic ultrasound findings, I would like to stress that the EUS is an underutilized modality for this particular indication, and there is plenty of evidence from the literature over the past maybe 15, 20 years that the EUS is a very accurate modality for the detection of common bile duct stones. So what we're going to demonstrate today is the station where we examine the common bile duct and of course the gallbladder to show you. And we're going to start by looking at the endoscopic screen. We are in the pre-pyloric position. And from this position, we can look at the gallbladder, and I hope we can switch to the EUS view. All of you can see the EUS view?
Yes, we have the EUS image.
All right, so if you look carefully, on the left side, you see the gallbladder, and many times the word sludge is used in a loose term. Sludge, there is no sludge. In this case, this is definite sludge. You can look, you have the cursor. You can look at the left part of the gallbladder, and you can see that there is a significant amount of sedimenting sludge in the gallbladder. And if you move your probe gently in and out, you find that in addition to the sludge, there is a stone with a nice acoustic shadowing. You can see it in the gallbladder itself. This information we knew from the previous examination from the CT scan. So what I'm going to do next is I'm going to examine the common bile duct. So I go first into the bulb, the duodenal bulb, and in this case, before I push it further, I can still get a good image of the gallbladder. You can see it on the upper part of the screen with the sludge on the left part. But if I go further down, and I'll be able to see the common bile duct nicely, and I'll demonstrate to you. So this is the common bile duct, and you can see next to it on the left part the pancreatic duct. So again, the cursor, please. So this is the common bile duct, and it appears dilated. We measured it at about 1.2 centimeters, and the pancreatic duct can be seen next to it running in parallel fashion. This is what we like to examine when we're looking for pancreas divisum or the stack sign. But in this case, we're going to be looking at the common bile duct. The upper part of the common bile duct, you can see it towards the hepatic hilum, looks dilated, but I do not see any stones. If I do go push my probe further down, you can begin to appreciate the presence of a stone at the lower part of the common bile duct. You can freeze it, please. And the stone is about 1 centimeter in size, and you can see a very nice acoustic shadow. It's about 1 centimeter. Unfreeze, please. And you can see that it's moving in and out. So it's a floating stone. Can you see it very well?
Yes, it's a very nice image.
All right. So we have actually, before we started the live demonstration, we saw 2 or 3 stones, right? Or we saw 2 or 3 floating stones, and obviously these have to be removed by ERCP. So one of the stones was not impacted, but was towards the end of the distal part of the CBD. So to examine this part, we have to push the scope down to the descending duodenum, and then we can look at the ampulla endoscopically. But what we're going to do, look at it, is by EUS. And if you look at the lower part of the screen, you're going to begin to appreciate the presence of, can we magnify, please, and look on the lower section, please? All right, magnify. Okay, good. So we're going to move the probe very gently with an upward movement of the big knob, and you can see here that you're beginning to appreciate the presence of a stone with the acoustic shadowing in the distal aspect of the common bile duct. This is the level of the ampulla, and very well you can appreciate this stone. It is, I wouldn't say impacted, but it's occupying the distal part. You agree, Erwin?
Yes, absolutely. It's very close. It's not impacted.
You can see.
Just a question. You're using the radial scope.
I'm using
this,
yes,
do you think it's better the radial scope or the linear scope to evaluate the CBD?
Can you just can you just freeze for a second? Before I answer this question, let me just go back a little bit. You can see that the wall here of the cursor, please, that the wall of the distal CBD is a little bit thickened, and this is not too uncommon when you have stones that are impacting in and out and floating because of the edema that results with that. But if you want to do an examination, I think you can do both a good exam using the linear or the radial. I personally prefer to use the radial for the examination of the common bile duct, but in every other aspect, including, of course, the FNA procedures, all of them, and the examination of the luminal lesions, I prefer to use the linear. But you can do a good examination with the linear or with the radial of the common bile duct. But probably one of the advantages of the radial is that you can see it from the bulb in a nice linear fashion all the way from the common hepatic duct all the way down to the distal portion. So I think this is a small advantage, but it's a matter of preference at the end of the day.
Assad?
Yes.
Oh, that was a nice demonstration of the role of the US in the depiction of the common bile duct stones. So you're going to perform the ERCP action.
ERCP with the extraction of the stone.
Okay, thank you very much.
Thank you.
Thank you for your demonstration. We go back to room number 4 because I know that Christoph is waiting for us to perform the biopsy.
It's not impacted.
Christoph?
It's
Thank
moving
you
in and out.
again. And as you can see on the right side, I try to get the lesion, the stiff lesion. You can see the homogeneous blue on the right side, and you can see clearly it's a stiffer lesion than the surrounding tissue. And as you can see, it's a totally strange position, but I need to get the lesion as, how to say, comfortable and without any vessels in front of me. Finally, it's not such bad looking, but I have almost never been biopsying in that position. So we have our needle right in front of the lesion. You can see it. We sharpen and introduce softly in that strange position into the lesion. So take it out and give the syringe and some sort of under pressure. I have been using the 25 needle because of flexibility, because it is not easy to handle the needle to get the tumor, the small tumor, you can take it out, in a good position. So we are waiting for the needle, but still I can play a little bit. It's not as, how to say, stiff as I sometimes have encountered ductal adenocarcinoma, but you might see that this is really somewhat awkward position, but it's without any vessels in between, and I do somewhat the fennel technique and try to get good material out of the lesion. And then we have the ROSE, rapid on-site cytological evaluations. You can close the syringe. I will put it up, relax everything, and then we might see how that happens.
Christoph?
Yeah.
Thank you very much for your great demonstration. This means that sometimes when you fail in a small center, probably it's better to send the patient to a high volume center to perform a difficult biopsy.
I'm sure it is like that, but I can very nicely imagine that looks so, how to say, nice lesion inside of the center, but you can see how strange my position is of the endoscope.
Yeah, we have seen you during the whole procedures.
Yeah.
So we go back to you just for the results of the cytological specimen, and so now it's my pleasure to connect directly to Hyderabad, to the Asian Gastroenterology Center. I see Professor Reddy already here, and thank you for waiting for us, and my friend Sandeep as well is very close. So hello everybody, welcome in Euro-Eus. So I give you the line so you can just introduce, and then we are going back to present from here your case. So Professor Reddy, is up to you.
Thank you. Thank you, Paulo. I hope you can hear us and see us. It's good morning, Milano, but afternoon here in Hyderabad. We are transmitting from the southern part of India, from the Asian Institute of Gastroenterology. My name is Nageshwar Reddy, and with me is the team who actually does all our ultrasound. Dr. Sandeep, of course, is known by everybody. Dr. Zahir, Dr. Radhika, Dr. Rakesh, and Dr. Mohan. We like to thank the Euro-Eus for giving us this opportunity to transmit from here. We have 3 or 4 exciting cases. And to start the first case, we have Dr. Rajesh Gupta, along with Dr. Rangarao, who's the anesthetist with this patient. And they will start the first case if we can have the case history on.
Okay, so we can start presenting your first case, and then we will give you the line back to this.
Okay.
Live from Hyderabad, we have a 29-year-old female with an episode of acute necrotizing biliary pancreatitis in December 2017, and a recent onset of abdominal pain and postprandial fullness, with blood tests showing only a slight increase of white blood cells and serum amylase. The patient performed an MRI showing a large walled-off necrosis of 14 centimeters. Today's scheduled procedure is EUS guided drainage, live from Hyderabad, Asian Institute of Gastroenterology.
Hi. Hi. Good morning, Milano.
Hello.
Can you hear me?
Very nicely.
Okay,
It's a pleasure for us to see you working live.
Okay. Thank you. Thank you. My name is Rajesh Gupta. I'm going, I want to thank Euro-Asian for giving us this opportunity. You have already heard the history of this patient. She's a young lady who is symptomatic for last 3 months, and she had developed a large W and walled-off necrosis, and my job is to drain this collection.
So you have the US image there, Paolo?
You have the US image?
Now,
Yes.
We have the US image, Sandeep, now.
Okay.
Very nicely.
So for the sake of time, I already explored the whole of pancreas. So it's a large collection which is spreading from head of pancreas to the tail area. You can see nicely the collection there, and you can appreciate This is a fairly large collection. It measures almost
more than
9 centimeter, more than 9 centimeter. And you can see nicely the walls, and there is debris as well. You can see the debris here. It's around 30% of the collection size.
Okay.
So the job is, so essentially whenever we drain all these collections, so there are essentially 4 steps. First we puncture the cyst with a needle. So the second step is, after puncturing the wall of the cyst, we can, so you can appreciate there is a fairly large cyst with a debris. So the job is to select the site
How's
of
the
puncture.
image quality there, Paolo? Paolo, can you hear me? Can you hear us?
We can
Can you
hear
hear us,
Sandeep,
sir?
very nicely.
Oh, okay. The image quality is okay?
Yes,
The EUS
yes,
image?
very nice.
Okay, good. So what Rajesh is doing now, first is we follow this 4th step. He'll puncture with a 19 gauge FNA needle. No.
So what type of stent are you going to use, Sandeep?
We will,
Professor Gupta?
We are going to use
stent?
specialized lumen opposing stents. So it is popularly known in our part as Nagi stent, which is developed by a Korean company.
Okay.
So that's the stent we are. This is a dedicated stent for.
Okay, I'll hold it here. It's already out, right? It's already out. No. We'll draw it.
So first step is to puncture, and the puncture site has to be.
I think we'll pull it back. No?
And
Yeah.
so you can appreciate the needle hub which is coming out.
Yes. Yeah.
Yes.
So you can appreciate the
Okay.
needle is already in. So the first step is over. Now we are going to place a long wire inside the cyst cavity.
So if the cameraman can focus on the fluid.
This appears to be little turbid.
Yeah.
Okay.
That's all.
So now the second step is we have to coil a wire inside the cyst cavity. Preferably we make 2 coils, at least 2 coils, so that we don't lose the axis. And then we exchange with the dilating. It's a graded dilatation before deployment of the stent. So first, because I'm going to use a metal stent, so I'm not going to dilate too much.
Do you have the fluoroscopy image also?
Can you have the fluoro image, please?
You can remove the room camera, fluoro and EUS image. That's right. Thank you. So the wire is now nicely coiled. There are 2 turns inside the cavity.
Can you appreciate that? Yeah.
Yes. Okay.
So now the second step is I'm going to make a fistula into the wall so that I can do a little bit of dilatation, which I'm going to do. So
we're using a 6 French cystotome which goes coaxially over the guide wire so that it can make a fistula between the stomach cavity and the cyst cavity. And then we will dilate this fistula with a 4 millimeter small caliber balloon so that it allows the stent assembly to go in easily.
the advantage of these metal stents is you need not dilate too much, because
Unlike
if you are
the
doing a plastic
yes.
stent where you need to dilate up to 12 to 15 mm, here you can dilate up to 4 to 6 mm because the device is not too big, so it can easily pass through the channel. Now you can appreciate.
He's got
my cystotome is already just touching the wall.
Yes, I think it's gone in.
Yeah, I'm already in. Can you appreciate that?
So the small burn which happened here, yeah, it was very nicely seen, Rajesh.
Yeah.
Those bubbles
Thank you.
ensured that the gastric wall
Sandeep?
and the cyst wall, yes?
So can we have only, okay, great. There's only one image at a time, because if you put two images on the same time, they are too narrow, okay?
Okay,
This is perfect.
Okay.
So now already I have made a fistula. Now I'm going to dilate. I'm going to use a 4 mm balloon. That is by Titan balloon. That is by Cook. So because I need not make a big fistula, big dilatation is not required because the assemblies of the stent is 10 French only. So we can easily pass.
So Rajesh is essentially doing entire procedure on the EOS mode.
So can you see the balloon is already there? And we have the endo, and you have the advantage of both. You can take advantage of the third eye also.
So you can also check the balloon on the EOS and fluoroscopy. थोड़ा push करना पड़ेगा और जाना अंदर जाना. Stop. Don't dilate. और अंदर जाना. हाँ.
In this way, it's perfect, Sandeep.
I'm sorry?
The image is perfect. That's great.
The image is perfect now.
Okay. So now you can see the balloon expanding.
The balloon is expanding through the wall, and it will make a hole inside the gastric wall so that Okay. So it is already dilated.
Just a small dilatation. We don't have to keep it dilated for a long time. And the last step is now deployment of this dedicated
lumen approaching stent.
This is Nagi stent we're using.
We call it Nagi stent in our part of the world.
So this is 2 centimeter long and 16 millimeter the diameter in the center. The flanges are 25 millimeter on either side. And this is a very soft stent. So that even if the cyst collapses, the inner end then does not hit the back wall of the cyst when it collapses. So the risk of bleed from the back wall is much lesser.
So we are ready for the deployment. The only concern when we deploy, we always make sure that the patient doesn't aspirate, because there is risk of aspiration. So I'm using a cap so that the fluid doesn't gush out immediately.
Just a question for both of you. What's the size of the stent you use? Are you planning to come back for necrosectomy in any moment? So are you planning to use a bigger stent?
No, this stent will expand on its own to the maximum diameter of 16 millimeters. And the aim of necrosectomy is not there at the moment, because once they expand, the fluid and some of the solid debris may drain out. Our indication of necrosectomy is only when the patient has symptoms because of undrained solid debris inside the cavity.
Okay. Can you appreciate that stent is already, I have pushed into the cyst cavity, and I'll ask my assistant to deploy. Can you appreciate you have the echo image?
Yes. I think that's okay.
Yeah. You can see the umbrella or the inner part of the stent opening nicely.
Yeah, very nice.
I'm going to come back wall of the cyst, a little bit traction.
That's okay.
And now we are going to show under endoscopy. Can you have the endo image, please?
We can have the endo big also if you want. Yes, very nice.
Very nice demonstration.
Fantastic.
Okay.
So it's a very easy step, and the stent is nicely opened up, and you can see the gush of the fluid in the cyst cavity. And this is the final flora image.
Oh, very good.
Okay. Sandeep?
Yes, Paolo?
Thank you.
Great demonstration. I think that all the audience has applauded your performance here. Fantastic demonstration. See you very soon for the next session. Thank you very much. Thank you very much.
Thank you.
Thank you very much.
We can go back to room number 7, because Alberto Mariani has already started the ERCP in the case of the young lady with this lesion, solid or mucous lesion into the pancreatic duct. Alberto?
Good morning, everybody. We have cannulated the pancreatic duct using the guide wire. And now, scopia. Contrasto. We contrast the pancreatic duct. Contrast, please. Stop. There is a dilated cephalic duct, and I think a filling defect. I try to avoid the possibility to verify the filling the fat because there was bubbles of air before opacification. Scopia. Opacification. Do you see the X-ray?
Yes, we have the center image, the X-ray, Alberto. It's a
Dilated Santorini duct. The minor papilla is well visible from the duodenal lumen. And now I try to better inject contrast just beyond the papilla. Contrast, please. Stop. There is a dilation of the duct, but it's difficult to distinguish the filling defect. Magnification, please. The passage of the sphincterotom is easy. I have no resistance during the passage of the sphincterotom. There is a filling defect between the dorsal and the ventral duct. It's possible that the lesion is plaques, mobile plaques, and now the plaques go up just to the bifurcation with the dorsal duct.
Alberto?
Do you agree?
Alberto?
Yes?
So you think that the plaques were right behind the papilla in the beginning, and with the catheter you have moved the plaques in upstream?
It's possible, it's possible.
Okay. So now what's your plan?
Plan is to perform a sphincterotomy and then to pass a balloon to remove the plaques. And in case of a negative effect, we'll perform a confocal to verify that the lesion is a plug.
Okay.
But, okay?
Okay. While you start performing the sphincterotomy, we go back to room number 6 where Erwin has started the ERCP, and then we will be back to you in 1 minute. Erwin?
Yeah. Okay, so good morning, ladies and gentlemen. So as you see, we are already trying to cannulate this this papilla, this nice-looking papilla. But I think this case represents very well the situation as it should be, because if you have a doubt or if you have a medium to low probability that there is a stone, before you start ERCP, it's better to have a US machine in your ERCP room so you can check exactly as Asa did before whether there is a stone or not before you embark on ERCP. So that's the situation at home as well. We always, when we are in doubt, we don't start ERCP, we perform a short US, we confirm that there is a stone, and then we go on. So now...
So Erwin, just a question, it's an important question. You think we should try to do an AUS before an ERCP as a routine?
No. I said when we have a doubt, or when there is a low probability, or when the case is not clear, or the imaging, the other imaging is not definite, before you embark on ERCP, we should do an examination that can confirm with certainty that there is an indication, a clear-cut indication, because as we know, ERCP carries risky, some complications that are really shouldn't be there if there is no indication. We shouldn't perform ERCP if there is no clear-cut indication. But as you see here, we are already in the common bile duct. Can you see the fluoroscopic image?
Yes.
Yes.
So I think we can inject. We can remove the guide and inject. We saw before that there are several stones there. So now we are starting our injection. And you see at least one of the stones. Oh, very nice. Okay. What's that? So we have the stones in the upper part. I don't see the stones in the lower part, but probably because of the injection, we did move the stones upwards. So I will calm down a little bit with the papillotome and try to inject in the lower part. And I think there is something there in the lower part, which is the stone that we saw, the filling defect, which was very close to the ampulla. And we see two more.
Can you ask to have a brighter image for the X-ray, because it's quite dark here in the audience, so we have a little bit brighter.
È scuro. L'immagine è scuro.
We try to manage.
It's better now? We see very nicely, but I don't know.
Here in the audience is a little bit dark in the screen. Now it's better, much better now.
It's better now.
Thank you.
Okay.
Yes, it's much better.
So I think we will proceed performing a papillotomy. And I'm trying to improve my position a little bit.
Ok, allora ragazzi, non
Okay, we are using the Airbus system. Can you bow a little bit, please?
Sì, va bene, quella mi piace.
The direction is a little bit otherwise that I would like.
Erwin?
Yes?
While you're performing the sphincterotomy, we go to the cytology room because Professor Doglioni has something to show us. We go back in 1 minute.
Okay, Arcare, play.
Okay.
I don't like this direction.
Dai ragazzi, andiamo. No.
Hi.
Okay. Okay. Claudio?
The procedure performed in room number 5, the cystic lesion. Obviously, the bioptic material will be processed and will take some time, but the smear performed after the other procedure showed us some fragments of epithelial cells that you see in the screen, I think, and just this remind me a intraductal papillary lesion with mild atypia. So you see the fragment is a large fragment of epithelial cells, monotonous cells, without significant atypia. So the material, it's difficult to appreciate. You have to focus up and down, but you see that the cells are quite monotonous without significant atypia. And also in the procedure performed in room number 3, the diagnosis is adenocarcinoma. I'll show you some field. This one, for example, you see a lot of debris, inflammatory cells, some normal cells, but this cluster here is composed by a typical very dark nuclei, so the diagnosis of adenocarcinoma could be done. Okay.
Thank you very much, Professor Doglioni.
Yeah.
So it's always a very nice demonstration.
Okay. Thank you very much, Claudio. Now we move back to room number 7 because Alberto Mariani is passing the balloon. So Alberto?
We have passed the balloon, inflated the balloon, and now pull back, waiting for the removal of something. Endoscopically, we can see some plaques material. Gonfiare un po'. We lost the guide wire, but we have removed something. Okay. Do you see some plaques fragments? Scopia?
Yes.
We try again to cannulate the pancreatic duct.
So with all of these findings, combining EUS, ERCP, and these removals, what's your impression now about the diagnosis of this case, Alberto?
But I think that this is a chronic pancreatitis case. Scopia. Balloon, please.
It's interesting. We were saying that even after the sphincterotomy, there was still no drainage of contrast. So it's definitely, there's an obstruction here. And the minor papilla is very prominent.
Do you see the plaques?
Yes.
That
yes, it's very nice.
is removed from the pancreatic duct. So I think that the diagnosis is that of chronic pancreatitis, and the filling defect was plaques.
It's almost like she's given
This,
herself a secondary divisum
So-
because of this block.
There is a dilation of the dorsal duct due to obstruction caused by the plaques just beyond the papilla.
Yeah.
Okay? Other plaques?
Oh. And so now we're getting some drainage of contrast after we've removed
Scopia.
all these.
Gonfiamo il pallone. Other plaques are removed.
So any question in the audience about this very nice and interesting case?
Yeah. So hopefully she's going to feel a lot better
Via il
after
filo, via il filo,
we
via il
relieve the
filo.
blockage and remove all these plaques.
Alberto, Ami?
Yeah.
Alberto, Ami?
We have reached, I think, the final diagnosis. And we'll finish the procedure placing a pancreatic stent to facilitate the drainage.
Great. Thank you very much for this fantastic demonstration on the combined role of EUS and ERCP in these particular cases. Thank you very much, Alberto. Thank you very much, Amy. And we go back to room number 6 because Erwin is waiting for us. Erwin?
Okay, so we did perform a papillotomy, which was quite difficult because the papilla is in a difficult position. As you can see, we are in the long position on the fluoro, and it was quite difficult to achieve the right cutting position, but we did it. And now we are dilating with the balloon. We do a balloon dilatation using a 12 millimeter balloon, which is about the size of the common bile duct that we measured before. And then I think we won't have any problem extracting these stones, which are 1 centimeter of size. So you see, I use, this is a special guide that I'm using for cannulation. This is the VisiGlide by Olympus, which actually combines the qualities of a good hydrophilic catheter and a stiff catheter guide, of course, not catheter. Now we are in with the balloon. Can we inflate, please? More. We go up to 12 millimeters. Okay. Is there any contrast in the balloon, or? Yeah, it's a little bit of contrast. We have or no? Yeah, we have. Okay, you can see the balloon very nicely in the fluoroscopy picture. And we arrived to the 12 millimeters, 3 8 atmosfere, 12 millimetri, which is, I think it's okay. We shouldn't dilate more than the maximum size of the common bile duct, not to cause any damage. So here we are. I think we are fine. We can deflate. There are all kind of recommendations on the time that you need to inflate and things like that, but I don't think it matters. So we will deflate and we'll pass an extraction balloon. We will, again, it's okay? Okay, now you can see that some bile is coming and contrast material is coming already from the common bile duct, which is nicely dilated. It's a little bit of blood, but this is normal. This is normal, and we go with the dilation, with the extraction balloon. This balloon has the possibility of injection below. Possiamo ingettare il contrasto sotto o sopra? Il palloncino. No, solo sopra. Solo sopra? Okay, so this is, we will be using the Boston balloon. Gradual balloon up to 12 millimeters. 9-12, 9 to 12. Okay, so 9 to 12 millimeters balloon. And actually we can almost see inside the common bile duct. You can see here. The balloon is coming and and we will continue with the extraction. Okay, we are arriving, and can we centralize the X-ray, please, so we can see the common bile duct in the middle of the picture? Okay, very good. Can we? You see the stone? We're just passing the stone there. Now, can you inflate, please? Balloon, yes. Okay, so we are on the stone, and we are bringing it down. So now do you have the endoscopic image as well? So you see a lot of sludge. You see a lot of sludge coming, and the stone. You see?
Yeah.
We have a lot of stones, a lot of sludge here. So we go again. I would like to inject a little bit of contrast to see what's going on. Can we deflate the balloon? Deflate? Deflate. Can we inject a little bit of contrast? There is another stone up there. Can we inflate now? I'm a little bit in, oh no, I'm just below. Now, can we inflate a little bit more? Maximum inflation? A maximum. Okay, but we are not bringing the stone probably. So let's have a look. We are bringing no. You see the dilatation was successful. We can pass very easily a 12 millimeter balloon, no problem.
Can we have the endoscopic image, please?
Now we go again back. Yeah, the stone is floating there. I will just try to aspirate a little bit. Sometimes it brings it down. Can we inflate now the balloon maximum? Or then
Can we change or switch to the endoscopic image, please?
Okay, we are bringing the stone now, maybe. Yes, yes. Yeah, I hope so. I think that we are... No. It slept. Okay. It's deflated? The balloon is deflated? Yes, deflated. Okay, then we go back there. Can we have a bigger... there's a 50 millimeter balloon? All right. So, but we are there already, so can we inflate the maximum a little bit more than it's... Okay. No, it slips. It's below. It's below. So I think we should switch for another balloon. Yes. It's bigger than 12. Okay. So here we are. Now we will switch for a bigger balloon. And then I think we will be able to take it out, and I think then we will be done because probably we cleared everything. We will do, of course, another cholangiography just to see if everything is right. But you see the size of the sphincterotomy and the dilatation is enough. Even if there will be some debris there or small thing, it will go out with no problems because the drainage is quite good now. And then we will be able to finish. So we are passing now the 15 millimeter balloon. We are passing this balloon, just a second, okay. We'll make it quickly. Here we come. And there we are. Can we inflate now the 15? It's the maximum. I don't know. I don't see the balloon. I didn't see the balloon. I go back. I go back. Now, can we inflate now? Inflate. It doesn't inflate, huh? Do you see the balloon? I don't see the balloon. No, I don't see neither. Oh, now we have the balloon. And now I got the stone, I think. You see it coming. It's a little bit difficult here. And
This is just a comment for the audience. I think it's we can have time for a coffee. The Erwin will keep on with the live. But if you want to go for a coffee, we will start with a lecture at 11. So feel free to have a coffee, come back. And we will keep seeing
okay, we lost
Erwin doing the ERCP.
I will pass maybe
Alberto.
not a while. Maybe I'll try with the basket. We'll try with the basket because it slips. Yeah, the bile that was very nicely on the floor. Yeah. So we have this. That's the first one. Non dorme, sì. It's above the it's just there, and it's a little bit. Ciao, prof. Come stai? Still one more stone. Bello, eh? Dernier. Ah. So now we had some difficulties to extract the stone with the balloon, so we will use a Dormia basket. And we will try to finish the job with that. So what type of a basket is this? This is a 2-4 or a 2-4 basket, standard basket. Yeah, I think it will be enough for this stone. Okay. Okay. Okay, open, please. Okay, you see the Dormia basket, which is open. I leave it open. And I think we got it. I think we got it now. And we will try to I think, oh, you see it's fragmented. It's fragmented. But we can close it. We lost a little bit the axis here. But we go back, no problem.
7. Erwin?
Yes?
Oh, you managed everything. Thank you very much for your demonstration.
Thank you.
So we go back to room number 7 because Alberto is ready to place the stand.
Yeah.
Thank you very much, Erwin.
Thank you.
Alberto? Alberto?
Okay, can you open? Okay, now we can inject.
Alberto?
No, contrast. Oh, shit, we are losing all the time.
Alberto?
Can you hear me?
Yes, we can hear you.
Okay. We leave a wire in place. And on the wire, I am going to put a pancreatic stent of 7 French, 9 centimeter length.
So we've successfully cleared the duct. There's no more contrast retained. So we think this was all obstruction due to the plaques, which have now been removed. But because of the inflammation from the balloon, we're going to leave a stent just to allow continued drainage.
Yes, just to facilitate the drainage, the pancreatic duct.
We have put the radiological image on the screen. Can you comment this radiological image for the audience?
Yeah. So there's a little bit of contrast opacifying the distal part of the pancreatic duct. That's just recently injected as we were trying to recannulate because we did lose the wire during the balloon sweep. And then actually we've opacified the bile duct as well, which you can see there also.
Yes, and the contrast in the pancreatic duct is completely homogeneous without filling defects.
Right.
So this is because you clean completely the pancreatic duct at the end.
Yes.
So.
And before just this recent injection, all the contrast had drained successfully after we removed all the plaques.
And I think that a good indication for pancreatic stenting is due to the trauma on the papilla region due to the passage of the balloon during removal of plaques.
But what's clear is that the EUS image was correct. There was certainly a filling defect within the duct that now we've removed, and hopefully she'll feel a lot better after this obstruction is relieved.
Yeah, the strange thing is that in the US image, it looks quite hypoechoic and homogeneous. How you explain this? Because usually the plug seems to be more hyperechoic.
Scopia.
Yeah.
Non mi hanno sentito loro.
I think that, for whatever reason, these plaques appeared more hypoechoic, but there doesn't seem to be any other lesion, both on contrast injection and balloon sweep. So, and now we've successfully put the stent.
Okay. Okay. Okay.
Okay.
I've chosen a stent 9 centimeter long, and the length of the stent is just above the genu. I think that was better, a longer stent.
Okay.
We have finished the procedure.
Adesso andiamo sulle mani.
Thank you.
I think that you want to show us something probably because we have seen great images from your ERCP, and I think that probably you want to show us something with the instrument that you have used during this examination.
Yes, you have seen elevator on the lateral side of the screen. This is because we have used Pentax duodenoscope with a disposable removable plastic cap. And this is a very important device to minimize the infection prevention, because we know very well that the elevator, do you see the elevator? Is a cumbersome side of the cap, then can be related to difficulty in cleaning. And a good property of this cap is to dispose of an elevator that can be well opening with an angle higher than that usually seen. And this can determine a good grasp of the devices against the elevator, in particular when you use guide wire, including wire with a hydrophilic shape. Another important characteristic of this cap, removable cap, is that we can reduce the time of cleaning, of the disinfection. We have about 35% reduction in time of cleaning thanks to this new cap. And now we can show the maneuver that is easy and safe of removal and placement of the cap on the tip of the duodenoscope at the cleaning room.
So thank you very much, Alberto. I think that in 5 minutes we are going to start the lectures by James Farrell. So we go back to you in 25 minutes at 11:20. Okay. Thank you very much.